Good day. I'm going to talk about the state of art and the future prospects for HIV vaccines. When you have a look at this, you can see that there are many interventions in the prevention toolbox, but one thing is missing is an HIV vaccine. And up until this point, it's been very elusive and we've been unable to add an HIV vaccine into our toolkit. Since 2015, we've been embarking on a strategy for HIV vaccine research, which entails both empirical and theoretical approaches. And the empirical approach was based on the RV144 TIE study. And this TIE study was shown to demonstrate modest efficacy. And when looking at the correlates of protection, it seemed that what was associated with protection was non-neutralizing antibody responses. So we went further to try and build up on this portfolio, using this as a basis to make vaccines that induced non-neutralizing antibody responses. And then there was a theoretical response, which was, could we induce or could we use broadly neutralizing antibodies to protect against HIV acquisition? And the two strategies employed there were looking at one with vaccines that induce broadly neutralizing antibodies using active vaccination, and the other was immunoprophylaxis, so it's broadly neutralizing antibodies. And so just looking at the slide, you can see that these approaches were, one, the active immunization to induce binding antibodies, and we looked at this in both HVTN 702, HVTN 705, and HVTN 706, and I will talk about the results of 702 and 705. The passive immunization was a proof of concept study, and here we looked at a broadly neutralizing antibody called VRC01. And this neutralizing antibody targeted the CD4 binding site. And I will also present the results of the HVTN 703 or AMP study to see if this is a way to move forward. And then further in the more theoretical, but probably the most important part of our vaccine development will be trying to find active immunization strategies that induce neutralizing antibodies. And I'll talk a little bit about this, but this essentially is trying to coax the immune system to develop broadly neutralizing antibodies using immunogens, for example, lineage-based vaccine design or germline targeting or epitope-based vaccine design. So if you look at our vaccine strategy, as I've mentioned, in terms of the empirical, we've been embarking on 3 phase 3 trials, phase 2B or 3 trials, and this is 702, 705, and 706. The 702 vaccine trial was a trial that was modified from the RV144 to be more clade C specific. The 705 used an adeno 26 mosaic vaccine prime with a clade C boost, and HVTN 706, which is ongoing, uses the same mosaic A26 with a different protein that has a mosaic protein as well. And then in terms of the theoretical approaches that we are using, we have phase 1-2 studies in play that looking at active immunization, and I'm going to talk a little bit about its role in preventing mother-to-child transmission. And then again, looking at the HVTN 703 or AMP study and the role of monoclonal antibodies in protecting against HIV acquisition. So this is where we sat in the last couple of years, and we find ourselves asking a couple of questions. Why did we do separate trials of non-neutralizing antibody vaccine approaches? And we did this because the correlates of protection may have some overlap, but there are many differences, and that we see that with the RV144 702, the V2 loop, the GP120 binding, ADCC and ADCP, and HIV specific T cell responses were correlated with protection. Whereas with the A26 regimen, looking at GP140 binding, the issue of V2 we are trying to establish, but definitely ADCP and ADSPOT correlated with non-human primate protection. Obviously, with these 2 vaccine trials, the magnitude and epitope specific responses and breadth differ. And this overlap and diversity improves our ability to find what non-neutralizing immune responses we need, or how they're correlated to protection, and will this lead to effective immune pressure so we can see vaccine efficacy. So in 2021, we've got the answers to 3 of the vaccine trials that I'm going to talk about. One with AMP, we showed in 703, 704 that there was a correlate of protective efficacy, and I'll be talking about that later. In the 702 vaccine trial, I will show you that this vaccine didn't work. And more recently, the HVTN 705 or Empirical vaccine trial also was shown not to work. And the only vaccine trial that's ongoing at the moment is the phase 3 Mosaic, which is the HVTN 706 study. So just quickly, the HVTN 702 or HAMBU study looked at the LVAC prime, double prime, and then a quadruple boost with the LVAC with a bivalent subtype C, which was adjuvanted with MF59. And we added the 18-month boost because we saw some issues around durability based on the data coming out of HVTN 100 and RV305. This shows the results of the NEJM study that showed that there was no protection in this trial, and that the efficacy was similar to placebo. So then thereby showing that this approach was not efficacious, and we need to go back and see if there were any correlates of protection in the study. Going on to the A26 J&J HIV vaccine program, this program was initiated by Dan Baruch using the A26 recombinant A26 vector priming. The mosaic inserts were designed by Betty Korber. There was a recombinant protein boost which was added after a trial called HVTN 505. And we based this on the correlates of protection were based on the low dose mucosal challenge in the rhesus macaque that showed the role of protection associated with non-neutralizing antibodies and T cell responses. So this just shows you the non-human primate challenge model that shows us that the addition of the A26 with a protein boost reduced the risk of exposure and showed protection to a 94% protection per exposure risk group, as well as full protection of 66% after 6 challenges. So based on this, we move forward with this trial. And also in terms of the non-human primate study, we saw the correlates were correlated to the ELISpot and ELISA responses, as shown here in a non-human primate SHIV challenge study. In addition, we also found that functional antibodies assessed by ADCP were also found to correlate with protection, as has been observed in previous studies. So we went ahead based on this data to implement the phase 2B proof of concept study, which was conducted in sub-Saharan Africa. And this was a vaccine trial where we primed with an adeno-26 mosaic vaccine at months 0 and 3, and then boosted with the A26 together with a GP140 clade C protein. We enrolled 2,637 women in 23 sites in 5 countries. And yeah, you can see just recently at the DSMB, after our recent unblinding session with the DSMB, you can see that in terms of the per-protocol cumulative incidence over time, this vaccine was moderate or mildly protective, but the confidence intervals overlapped, and so we have no significance. So there again, this vaccine in this proof of concept study failed to protect. There was a hint of protection between 18 and 24 months, but this was not persistent, and there were overlapping confidence intervals. Looking at this vaccine beyond 24 months of age, we've been unable to demonstrate any level of efficacy. And as you can see, the placebo incidence is still very high at 4.32 as compared to the vaccine incidence of 3.61 with overlapping confidence intervals. So just moving on to the last phase 3 trial that's still ongoing, and looking at the difference between the Empirical and the Mosaic. First of all, the Empirical was a phase 2B proof of concept study, whereas the Mosaic is a fully powered phase 3 study. The inserts, the protein insert is a bit different. We had a clade C GP140 in Empirical, and in Mosaic we've got a bivalent GP140, which includes both the clade C and the Mosaic. The countries are different, the population is different. In Empirical we had women, and in the Mosaic we have MSM and transgender individuals. Different clades, and we may see in the Mosaic more PrEP use, and the transmission in Mosaic is different, which gave us the impetus to continue to evaluate this regimen that was similar to Imbocoda in a different population in a well-powered study. So what are the implications of this lack of overall efficacy we've seen? It's important for us to look at the correlates data that will inform future decisions. Can we boost Mosaic or alter the schedule in a rational way if we find out what the correlates of protection are in 705? And as an HVTN, as an organization, we will have to deprioritize all non-neutralizing approaches unless we see something incredibly special that's different, both qualitatively and quantitatively from what we've seen from the 702 and 705 regimens. We now need to focus on inducing neutralizing antibodies, and I'm going to show you data from AMP that shows that we can, this study may pave the way to give high-grade prevention from acquisition, especially if we achieve this at more than one epitope. So just to go back, the AMP study was it was called VOCO1, a preformed broadly neutralizing antibody that targeted CD4, and I'm going to show you data from this study. The study was conducted between 2014 and 2020, both in sub-Saharan Africa and in the Americas, in two different groups. In the sub-Saharan Africa, it was heterosexual women, and in the Americas, it was MSM and transgender individuals. The study was published in the NEJM and in the Cell Host and Microbe. And yeah, you can see that there was protective efficacy in the area in amongst the most sensitive viruses, which is about 60 to 80%. And this was consistent after 2 doses, and definitely showed a protection in the sensitive viruses. However, the protection efficacy against more resistant viruses was near 0 by 80 weeks. Yeah, this slide this first plot just shows you that the least neutralizing resistance was associated with high protective efficacy, and the higher the resistance of the virus, the less likely it was to protect against acquisition. And yeah, you can see by doses, both the 10 milligrams per kilo and the 30 milligrams per kilo in the low resistance viruses was highly effective. So this is important. We now know that if the virus is sensitive to the antibody, you can predict efficacy. And now we need to work against trying to find monoclonal antibodies as cocktails that could try and override the issue with resistance. So this moves us to the trying to induce neutralizing using active vaccination, either using stable trimers or lineage-based vaccine design, or germline targeting or epitope-based vaccine design. And this just shows you the various strategies that are entering the HVTN for evaluation, trying to induce HIV-specific neutralizing antibodies with various targets in their approach. And then also to look at how this could play a role in certain agendas like the PMTCT agenda. And here we know that babies induce more broadly neutralizing antibodies than adults, and we are using children children born to HIV-infected mothers who are being breastfed as a proof of concept study to see whether we could correlate with what happens in children as what happens in adults. And yeah, we can able to compare both adults and children in a direct comparison in the study. Just finally, in conclusion, I want to say we do need to continue our HIV vaccine endeavors. We now have results of the efficacy studies, and we're waiting for one more study, the Mosaico. It's important for us to do correlates of protection work to inform future designs. The AMP study provided proof of concept for the use of monoclonal antibodies to prevent HIV acquisition. And we now need to look at monoclonal cocktails of monoclonal antibodies to see whether this has a role in our toolbox. And we will need to work hard on active immunization studies to induce neutralizing antibodies to inform future strategies, particularly in the role of PMTCT and heterosexual transmission. So 2021 was a pivotal year for us. We know that the answer to the role that body neutralizing antibodies play in in protecting people against HIV acquisition, and we need to work on developing this route. We know that the AMP works, and we now need to follow that road going forward. We need to continue to make the public and funders aware of the need for an HIV vaccine, and we need to get reasonable body neutralizing antibody regimens into clinical trials. And it's very important to do this. We must make sure that we don't lose HIV vaccine exceptionalism, and we need to see, we do know that HIV vaccine development was like NASA for COVID vaccine development, and can we achieve a reverse equation, and can COVID-19 vaccines help speed up vaccine development going forward? I'd like to finally acknowledge everybody involved in these studies, most of all the participants who join us in this journey to find HIV vaccines. I want to acknowledge the HVTN, particularly Larry Corey, as well as DAIDS and the vaccine research program, and all the people that are involved in making this work from all over the world, and our funders. Thank you very much.